All right. Thank you, Kara. Appreciate it. We do have questions, a lot of questions. What penalties, if any, will be incurred if one does not specifically add and code an exact strain of antibiotic resistance?
So you want to check with your payer. It's going to be payer specific. You may not have a penalty, but your claim may be rejected or denied. So your penalty could be no payment at all. Again, check with your payers, pull your most common payers, and go ahead and reach out to them. Find out what their claim edits are going to be.
And is that something the payers will know now?
Hopefully. Yes, they should know now. Most of them, they may say, well, we're using CMS edits, which we know are going to be relaxed. So in that case, this user wouldn't have a penalty. But definitely take advantage of that 12-month leniency to familiarize yourself with the code so that you're not, because after 12 months, they're all going to really tighten things.
How many diagnosis codes are really needed? I usually have 4 on a claim. I'm a chiropractor.
Okay, so yes, then you're fine. There are, on a claim and on the claim form, you can have 12 diagnoses on there, but the diagnosis pointers for each procedure that you perform, you can only have 4 pointers. So as long as for each thing that maybe you're performing the subluxation, if you're also doing some different manual therapy, as long as the 4 diagnoses that you're using on each of those line items are applicable for those procedures, then you're fine.
Should we avoid putting September and October service dates on the same claim?
I would. I most definitely would. We have had some payers say, you know, it's fine, we will be able to process those. I personally would avoid doing that.
Just to be safe.
Just to be safe. We don't want to leave it in the payer's hands. Let's give them as much clean information as possible to avoid any kind of denials.
As you said, we went through the 50-10
right,
transition
exactly.
and know how they handled those
exactly.
things. What version of the CMS 1500 did you indicate we were to use?
It's the 2014 version. So it actually came out in 2014, and some of you have already been using it. And if you've ordered claim forms recently, that's probably what you've received. It's become a little bit harder to get the old claim forms. So when you go in and look at it, you'll see it'll say 2014. I think that old version is like 2008 or something like that, but it'll be 2014 1500.
Print on the bottom?
Yes.
I have heard that pain codes are not recommended to use as a primary code. Can you advise? As a physical therapy practice, we typically use pain codes as our only ones, our only codes.
Yeah, and you will. For physical therapy, you will use pain codes. You're going to be coding off of the signs and symptoms. Obviously, if you're getting a referral from a provider and there is another diagnosis code that they're using, then you can use that. But for physical therapy, yes, you may have someone that has shoulder pain, and I know with physical therapy we have lumbago with the back pain, so you are going to have those type of codes.
If a claim has been submitted previously, do we start from that point for subsequent visit coding, or since this is the first claim on October 1st, should the initial visit code be used?
No. So you will use the subsequent because you have already been treating this patient for that diagnosis. So only the very first time that you see that patient for that condition will you use the initial encounter.
Okay. So you're saying that it is mandatory for the offices to be ready for ICD-10, but not the payers?
It is. It's really mandatory for everyone to be ready for ICD-10. But just like we had with 50-10, it was also mandatory to be ready, and unfortunately, they just weren't. I really don't think we're going to have so much of an issue with ICD-10 because a lot of payers, clearinghouses, providers, all of us had already begun a couple of years ago, because we thought this was going to be October of last year that we were going to have to use ICD-10. So many of them already had things in place. Not all of them, and yes, that's correct. I don't know that there's going to be any penalty for those that aren't. And workers' comp, personal injury, auto, they don't necessarily have to use ICD-10. That's why I say make sure you're checking with your payers.
I know you've been involved with the payer testing. What percentage of payers would you say went through the testing and passed?
Well, really a good number of them. I would say probably 75% of payers had some sort of testing, whether a direct submission testing or they were doing some testing with their clearinghouses. So even though you may not have participated from a provider standpoint with testing, likely the clearinghouse that you use or the software vendor that you use was testing. I know here at NueMD, we tested direct submissions, and some of that testing for some of those payers was very simple. They would work with the EDI departments and say, hey, send us a claim that has 10s. We just want to make sure we can receive it. So that's what most of the testing was about, not necessarily anything to do with edits as far as yes, it was more just to make sure that they could receive and read that 10 code versus a 9.
So we may not really know until 30, 45 days down the road
exactly.
when people are not getting paid or not.
Right, and that's why we try to anticipate everything. We just can't anticipate everything. We don't want to be left to the mercy of the payers. So that's why I say we really want to follow up. Make sure you're following up on everything. If you're not getting claims logs after you submit your claims to confirm that those were received by the clearinghouse and or the payer, get someone on the phone calling. You don't want to sit around and wait and then be out of time. Another thing is also with keep your timely filing in mind. Many payers have timely filing. You don't want to wait around and then call a few days before they say, well, you're 2 days away from the timely filing limit, and all of a sudden you've got to get a claim to them, a clean claim. So keep that in mind as well.
Medicare has stated that they will not be basing payment on specificity for at least the first year of ICD-10. Mm-hmm. Does that mean we can use NOS codes as long as they are in the correct physical area?
As long as they are in that area of the ICD-10, you're not going to have many of those codes. But yes, what they're saying is if you choose a code within that subset that may not be the most specific, they're still going to process and pay your claim. Try not to do that. And if you are doing that, I would recommend if you're a provider or you're a coder or biller and you're getting those non-specified type ones, even the ICD-10 non-specified, make a list of that. Make sure that you're keeping track of that and that you get with your providers and say, hey, these are the ones you've been sending us to code or sending us to submit claims for that really aren't specific. Let's take a look at the ICD-10 book and see what would be specific. So by the end of that year, you're no longer doing that.
Okay. If you are entering a claim after October 1st for services rendered prior to October 1st, which code would you use?
9. So if the date of service is prior to October 1st, you're going to bill those with the ICD-9. Regardless of the date of submission, it's based on the date of service.
I work for a chiro clinic. I'm confused about the 7th character. A is for initial encounter, but D might possibly be a maintenance code which isn't covered under chiropractic care. Do we always bill an A?
No, you wouldn't necessarily always bill an A because really the A is only going to be used the first time that you treat that patient. So your 7th character, if you're seeing the patient, maybe it's not for maintenance, as you mentioned in your question, chiropractors can't bill, Medicare won't pay for maintenance. But if a patient has an ongoing issue that you're treating, the first visit, you're going to bill with the A. The subsequent visits, you're going to bill with the D to say that this is ongoing. This patient is still being treated for this condition, but this isn't the first time that I'm seeing the patient with this condition.
Is there any difference for out-of-country claims, or do you know?
Well, you really, again, you have to check with the payer. Like I mentioned at the beginning of this, many countries already have been using ICD-10. We're really behind the 8 ball with ICD-10. So a lot of them, depending on who you're billing to, already
be
want
using them.
Exactly.
Doesn't the CMS 1500 form that had to be used beginning in 2014 have a revision date of 2/12 at the bottom right corner?
Yes, it might. Yeah, it may have at the very bottom in parentheses a 2/12. And you know that's the one. And then look at it and see, you'll see the differences in it. You'll be able to see the additional for up to 12 codes, and then you'll see the little spacing in there for the indicators that are next to the codes.
Okay.
But yes, great question. I think you are absolutely correct. I think it does say 2/12.
And that may have been my mistake. I think I said something about it to look at the bottom. So you can blame me. We are a new billing company having August and September claims pending. Can I submit these claims with ICD-9 codes in October? Will the payers still accept these claims?
Yes. So again, it's going to be based on date of service. So even if you're submitting the claim mid-October, if the date of service was for, back in September, August, you're going to send the 9.
We treat children PT, OT, ST, and typically are seeing them as a referral from their primary care physician. So our encounters would never be an initial encounter unless we did an evaluation prior to them seeing the PCP, right?
Yeah, it's not the initial encounter. I would check with the payer on that. The first encounter really with any provider regarding that care should have the A. So yes, you're most likely right that yours would not have the A on there because you're not establishing treatment for that. But check with some of your payers just to make sure that that's the way that they want them.
If you see a patient and have to retest them in 4 months, we no longer use the A in the diagnosis code, correct?
Correct. Then you would use the D for the subsequent.
That's all we've got. Kara, thank you. I appreciate the time today.
Sure.
I know things are really busy for you right now, so we appreciate it. For all you attendees, thank you for taking time out of your day. We hope you found this valuable. So thanks again, everyone, and I hope everybody enjoys their weekend.